So we have some really prominent speakers now in this coming clinical trial section. We have two speakers that come from the human fields, persons that have been very engaged in the large clinical trials that's been performed, landmarks trials in people. I think that the communication now with the information coming from the human field over now to the veterinary field is important. Although I think we should always keep in mind that we see a slightly different spectrum of disease. We're primarily interested in mitral valve disease, which is a problem that I think is less of a problem in people because they tend to do surgery on their patients, which is usually not an option for our patients. Nevertheless, really interesting information when it concerns the pathophysiology and also our treatment options. So with that, I would like to introduce the first speaker, a prominent speaker. It's Dr. Faiez Zannad, who is a professor of therapeutics and cardiology and is head of the division of heart failure in Nancy in France. He's been very engaged in many of these landmarks trials, such as the RAILS, the Valiant, the CBIS, the Capricorn, Ephesus, and the Emphasis trial. And it's a great pleasure to introduce him. So.
Good morning. Thank you, Emily. Thank you, Sylvie. Thank you, Siva. Thank you, Bordeaux. Sunshine. I'm going to speak today on behalf also and under the control of Bert Pitt, with whom I paired over a couple of years, and to tell you a story which has been unfolding over now 15 years, and mainly in heart failure, but I will potentially also cover other areas of cardiovascular diseases where aldosterone antagonists may help, at least in human medicine. These are my disclosures. And this photograph, not only because the eyes here are matching my colors of my slides, but it is also because this lady died from heart failure this year. And heart failure is a devastating disease actually in human medicine, and if you just plot the survival of heart failure versus many other diseases and especially cancer, you can see if you are a woman, you better have a breast cancer than heart failure. So certainly any progress in this area, it has major public health impact, and when we have got drugs with life-saving property, it's certainly great advances, and I will show you how much not only with aldosterone antagonists but also with many other drugs in heart failure we have really made a huge impact, at least in systolic heart failure. Now, coming back to MRAs, and this is the way we'd like from now on to call aldosterone antagonists, because typically, I will show you a slide later on, there are many ways to interfere with the aldosterone pathways. One way is to block the mineral cooperative receptors with specific antagonists, and this is a new class we'd like really now to nominate as MRAs. And we have really gone a long way. You have heard this morning lots of changes in the paradigm, and when I was a young student, this is what I have learned, that converting enzyme inhibitor block the renin-angiotensin system, including aldosterone production, and Alan has done a great job showing you that with the escape or the breakthrough, you name it as you wish. Actually, this is not true. And we had also the conception that MRAs act on the kidney and the diuresis, sodium, potassium. We have talked about that this morning, but now we do find out that there are receptors, MRs, all over the body, and especially in the heart and the vessel, and with functional properties. And finally, at the late 90s, all limelight was about converting enzyme inhibitors, and combining an MRA with a converting enzyme inhibitor was actually forbidden in the guidelines and also in labels because of perceived risk of hyperkalemia and worsening renal function. So we had really to fight against all these conceptions until we came with the data I'm going to be sharing with you today, that there are independent and additive action beyond converting enzyme inhibition, or actually the renin-angiotensin aldosterone system inhibition. And there are extra-renal effects which are extremely important that I will show you some mechanistic data. And finally, that it is safe, but at least the benefit to risk ratio in combining an MRA with a converting enzyme inhibitor is positive, and these are life-saving drugs. But there are some safety issues, and I will address a few together. So the evidence in heart failure comes from two extremes of heart failure. One, the very severe cases, and this is the slide you have seen already with the RALS trial with a 30% robust benefit on prevention of all-cause death. And this was the end of the spectrum. Severe heart failure, class 3s, patients who have been hospitalized for worsening heart failure. At the end of the spectrum, you have got de novo heart failure in patients with coronary artery disease and acute coronary syndrome. And this is the Ephesus trial, patients with low ejection fraction, symptoms of heart failure within the setting of acute myocardial infarction. So we have got here the two extremes of the spectrum of the disease with a very consistent effect on mortality. And the new contribution we have published early last year was the filling the gap, which is mild heart failure, but still in the left ventricular systolic dysfunction. And these were the inclusion criteria of what is called now Emphasis HF trial. These were patients in class 2. Upon randomization, they have very few symptoms, so mildly symptomatic, but still they had low ejection fraction. We are in the area left ventricular systolic dysfunction. And in order to enrich the event rate, we had to select patients with recent history of cardiovascular hospitalization or additional risk factors such as elevated BNP or large QRS. Of note, we have excluded patients with hyperkalemia or risk of hyperkalemia because of poor renal function, and potassium-sparing diuretics were not allowed into this trial. And this is essentially the result of Emphasis HF. I've put these on the same slide than RAS, and you can see actually how different are these trials, just showing the event rate. This is really mild heart failure as compared here to severe heart failure. You can see the 1-year mortality rate here in the placebo group was above 25%, and here only lower than 10%, about 7%. So this is mild heart failure. And this complements nicely the proof of concept and now the evidence that this class of drug is effective throughout all the spectrum of heart failure with low ejection fraction, and again with primary endpoint, but also with a number of other secondary endpoints. This is the cardiovascular death and hospitalization for heart failure, which was the primary endpoint, a very robust 37% decrease in this primary event. Most notably and consistently with other trials, all-cause mortality was also decreased significantly, here by 24%. It took some time before the curves diverge. We are instructed from statisticians that we should not really too much speculate about the shape of Kaplan-Meier curves, but if you can try speculation, this is probably because you need some remodeling, especially in the extracellular matrix, in order to have the benefit on heart failure unfold, the benefit on all-cause mortality unfold later. So as a result, and having a step-by-step approach to treatment of heart failure, this is where we were in the late 80s with the first converting enzyme inhibitor trial, Consensus in severe heart failure. This slide is moderate to severe heart failure, and after Consensus, we have had the RALS trial, and you can see we have dropped mortality rate significantly, and with the addition of beta blockade in severe heart failure, we have decreased even further the mortality rate. So in a trial now, or population in trials in severe moderate heart failure with low ejection fraction, this is where we came from, 35% mortality rate down to 13%. I don't know any other area in cardiovascular medicine where this kind of progress has really been approached and achieved. And similar to this, we have the same progress and same benefit in mild heart failure. If you plot here the SOLVE treatment trial, first trial with converted enzyme inhibitor as well, with enalapril. We came from 15.6% mortality rate down to the active treatment group here to 6%. Again, threefold decrease of all-cause mortality in these categories of severe, moderate, and mild heart failure, a very important achievement. Now, as practical messages, what are the target population as a consequence to all these three accumulated evidence from these three trials? Certainly, the benefit extends to all the spectrum of symptom severity in all patients with left ventricular systolic dysfunction, and of course, all trial excluded patients with poor renal function, on average eGFR below 30 or 40, and patients with hyperkalemia or taking potassium-sparing drugs. And these are really essential because in clinical medicine, we need to monitor potassium and take care of these safety issues. I'll get to that later. So that from these three trials in chronic heart failure, certainly we would advocate to initiate treatment in stable condition with chronic heart failure. In acute heart failure, we don't have any data because acute heart failure is an area where there is a quick worsening of renal function and rapid changing in the renal function. So therefore, it may be challenging to initiate patient. So we'd rather recommend that we wait until patient is discharged and renal function is stabilized before initiating this treatment. And finally, in acute myocardial infarction with left ventricular systolic dysfunction and heart failure, this is the result from Ephesus, we need to recommend treatment as soon as possible. Actually, after the third day, the Ephesus trial randomized patients between the third and the 14th day after onset of symptoms of myocardial infarction. And we have done a sub-analysis, and we did find out that patients who were randomized early in the third or fourth day benefited most as compared to patients who were being randomized in the 10th day or so. And as a consequence, there are two other trials running right now with an even earlier initiation of treatment within the 12 to 24 hours after symptoms of myocardial infarction. So this is a super acute administration of the drug even before you got potassium and creatinine tested. And adapting, of course, doses accordingly later on. And this is the reminder and Albatross trial. Hopefully in 2 years' time, next meeting, we may share the results of these two trials with you. So this is an extension of earlier intervention in the acute coronary syndromes. Now, a couple of very practical issues, the dosing and safety, and these are very much interrelated. Safety of the drug is very much dose dependent, and this is certainly one of the most smart move Bert Pitt has done when we started thinking about doing the RAS trial. At that time, spironolactone was used at 7,550 milligram per day for treating heart failure. And Bert speculated that we may be safe enough but still efficacious with much lower doses. And as a proof of concept, they have done a trial with natriuretic peptide, atrial natriuretic peptide, and you can see that doses as low as 12.5 milligram were already active on BNP, which is a measure of stress and hemodynamic remodeling. So we've elected to start the dose at 12.5 and not go beyond 50 milligram. And this is because the risk of hyperkalemia is totally dose dependent. And you can see that up to 25 milligram, you don't run the risk into getting in hyperkalemia, but beyond this, you have a higher rate of hyperkalemia. And hyperkalemia actually is something common to all renin-angiotensin aldosterone system antagonists. The data we have from the three aldosterone antagonist trials are very consistent with all trials with ARBs and converted enzyme inhibitors. This is actually an inherent risk in the treatment of heart failure with renin-angiotensin aldosterone system antagonists, and there is rate of hyperkalemia or risk of hyperkalemia is not higher with MRAs as compared with adding an ARB to an ACE inhibitors, for example. So this is something really important to take into account whether you are using a renin inhibitor, an ACE inhibitor, an NARB, or an MRA, and a couple of few information on the risk of hyperkalemia coming from the emphasis trial, very consistent with the Ephesus and RAS trial. If you stay in the safe side, not enroll patient with worsening renal function or poor renal function and no potassium supplements, you do see more hyperkalemia reported as adverse events. You do see more hyperkalemia reported as a biochemical measurement. But when it comes to serious hyperkalemia or life-threatening, no statistically significant difference. And when it comes to hospitalization for hyperkalemia, which was actually adjudicated in this trial, again, no difference, and the numbers were very small. And another very nice information here is that in the placebo group, the rate of hyperkalemia, you see here, potassium over 4.5, is not only at all uncommon, which is what I said earlier, inherent to the risk of hyperkalemia in heart failure with converting enzyme inhibitor. But the bottom line is that if you stay on the safe side, no natural patient with poor renal function, do not use potassium supplements, and monitor potassium continuously, this drug is safe and you can really maximize the benefit from it. Now, I'd like to share with you some data on pathophysiology and mechanisms. The way we can see how the drug acts is using biomarkers, and I know that there is going to be a session on biomarkers later today, which is really interesting, and we do tend to use this increasingly not only to try to understand pathophysiology, but also to guide therapy. One of the major mechanisms has been highlighted earlier by the group of Carl Weber and many other people on experimental basis, that left ventricular hypertrophy and left ventricular fibrosis are very instrumental into getting to heart failure and sudden death through producing arterial but also left ventricular stiffness, which produces diastolic dysfunction, but also producing heterogeneity of contraction and heterogeneity of electricity, producing the anatomical substratum of heart failure and also of sudden death. Now, we can measure this using P3NP or many other biomarkers of extracellular matrix. This is what we have done in the RAS trial. I have shown this slide 2 years ago, and this actually is basis of lots of new trials we are trying to prepare right now, stratifying patients on their baseline level of P3NP, because baseline level of P3NP are very predictive of outcome on the one hand, but also predictive of the efficacy of the drug. You can see that patients with high level of P3NP benefited most from spironolactone when compared to the other half of patients with low levels of P3NP who have virtually no benefit. So we are now testing prospectively whether stratifying patients depending on their level of P3NP may help avoid giving the drug unnecessarily to some patient who would expose them to side effects with no clinical benefit, and rather maximize the benefit in a group of patients with high rate of extracellular matrix turnover. Very consistently in acute myocardial infarction, we have shown essentially the same result. In acute myocardial infarction and the placebo, you have a very important stimulation of inflammation and fibrosis, and which is totally blunted by the effect of eplerenone in this case, and maintained throughout the at least 9-month follow-up in this trial. So this is just to show the consistency of this result in two separate settings: acute remodeling of the heart and chronic remodeling in the RAS trial. How this is clinically important, I've said that these are instrumental in progression of heart failure, and I have shown you that rehospitalization of heart failure is prevented by the drug, but how much sudden death and arrhythmias are influenced by treatment. This is a slide showing the result on sudden death from RAS, from Ephesus and emphasis. Very consistent data, hazard ratio between 0.7 and 0.8, so on average 20% reduction of the risk of sudden death, which was statistically significant in RAS and Ephesus. This was not statistically significant in emphasis because these were patients at low risk, although the numbers pointed out exactly the same direction, the numbers were so small that we didn't really reach statistical significance because of large confidence interval. But the consistency of the result adds lots of credibility to the potential benefit of avoiding ventricular lethal arrhythmia and sudden death. Now, there is another arrhythmia which is very relevant in heart failure. 30% of our patients who would run into atrial fibrillation sometime, and you know that this initiates a vicious circle, atrial fibrillation aggravating heart failure and vice versa, heart failure aggravating atrial fibrillation. And from dinner chat we have had yesterday, I understand that actually lots of your patients are in veterinary medicine exposed to the risk of atrial fibrillation as well. And the good news is that using eplerenone prevents new onset of atrial fibrillation. So if you start early enough, you can have a very significant benefit on preventing your patient into getting in new atrial fibrillation. We have done other biomarkers showing all very much consistent results on various neurohormonal stimulation and inflammation. This is osteopontin, very important up in the cascade of inflammation and producing fibrosis, significantly influenced by treatment with eplerenone. BNP, of course, as you may have expected, and of course endothelin and lots of other biomarkers which are influenced in the same direction. Now, one question very prevalent in human disease is whether we should be using eplerenone Spiro. Spironolactone was used in RAS, eplerenone in the two other trials. Spiro is available in the market, generic, cheap. Eplerenone is still expensive. So whether it's a class effect and whether we should be using either or, I will show you just one slide, and this comes from work of a group from Japan. Explaining actually how much it is important to have selective MRA, meaning you block only aldosterone, and this is the case of eplerenone versus Spiro, which is not selective because it may also have a feedback on cortisol. What is shown here is a patient with heart failure and diabetes, and you see glycated hemoglobin, glycemic control, which is worsened by Spiro as compared to eplerenone. Eplerenone has no effect. So Spiro, but not eplerenone, worsened glycated hemoglobin. Why is that so? In this study, they have also measured cortisol. And because of the feedback loop you have heard earlier, and because of the selectivity of eplerenone, cortisol level is not influenced by eplerenone. It was raised by spironolactone feedback. And as a matter of fact, there was a very close relationship between the rise in cortisol and worsening of glycated hemoglobin. So just one piece of evidence. We may show more, showing that there is no class effect, and I'm sure that you guys are very well aware that these are all different animals, and class effect, I don't believe it in pharmacology. Now, just to end with a couple of summary slides, we now have a better understanding of how MRA work, at least in the cardiovascular system, and you have seen lots of these pathophysiology discussed this morning, moving away from only sodium and potassium handling and reabsorption, all the way through the direct effect on fibrosis, endothelial function. Alan Struthers have really contributed very much on the effect on endothelium of aldosterone antagonists, and also on coagulation. Heart failure is a thrombotic disease, and there are lots of work ongoing here on the effect of aldosterone coagulation. So all factors which may be important into the progression of heart failure and sudden cardiac death. And we may conclude that we really have succeeded to change practice, at least in systolic heart failure. And if you move on here to patients with all symptomatic patients with low ejection fraction, provided they have no severe renal dysfunction, the guidelines are now moving with level of evidence 1A to using a converting enzyme inhibitor. This is been repeatedly shown. a beta blocker, but the third drug is now definitely an aldosterone antagonist. So this is the three minimum drugs all heart failure patients with low ejection fraction should be taken. And in the subset of patients with LBBB, left bundle branch block, stimulation and using base PK may help. Now, there are lots of new indications ahead. Here we are having the current indications, systolic heart failure, some cases of hypertension, but certainly moving upward to the high normal blood pressure, people at risk of, now that we have a safer drugs and efficacious, and moving along acute coronary syndrome with systolic heart failure, but also starting very early upon admission. Other areas are cardiovascular prevention in chronic hemodialysis, a huge cardiovascular event rate in the subpopulation. We have started a trial into this area right now. And a much larger potential market is patients at high risk of cardiovascular events. So we are here in the prevention state. This means diabetes, metabolic syndrome, but we know how much fibrosis is really instrumental in progression to heart failure and cardiovascular disease in this area. Another development is refining new drugs. So not only new indication, but there are new drugs on the horizon. Some of them are MR antagonists, and refining the concept of more selective cardiovascular targeted drugs with less or fewer side effects on the kidney. And we are moving along this way, and we are now have some of these drugs being under clinical testing. And finally, also another category of drugs. So far, we know how to block MR with a number of MR antagonists. Some of them are smarter, being more selective. But there is another path, which is blocking synthesis of aldosterone with aldosterone synthase inhibitors. And there are now also a couple of these are available, not only in preclinical, but some of them have started in clinical development. So the pharmacology of this class of drugs is being very much enriched and refined. Now, there is a real big competition between these two categories of drug. Who is going to be the winner? I don't know. We'll see in the next few years. So this is my final slide, just showing that this unfolding story of aldosterone pathway in cardiovascular disease is still to be completed. We have better understanding of pathophysiology. We have now proven the concept that these are life-saving drugs with many potential new indications, and we have many more newer and hopefully safer MR antagonists and maybe other classes of drugs acting in this pathway, which may be also useful into widening the indication. Thank you very much for your attention.